Good morning, everyone. It's a pleasure this morning to introduce Anna Shree. Anna's a relatively new PhD student in the National Centre for Antimicrobial Stewardship and the Asia Pacific Centre for Animal Health. Anna is a veterinary graduate from the University of Queensland. She spent some time in practice, then returned to her alma mater to complete a Master's in Public Health. She spent quite a bit of time in practice. She's worked in Darwin, worked in programs with dogs in Indigenous communities while she was there, but is now based on the Sunshine Coast. Still puts in some work in practice in between managing to do her PhD work. And her presentation this morning is going to be on veterinary prescribing in Australia, the use of high importance antimicrobials. So thanks, Anna. Take it away.
Thanks, Glenn. Good morning, everybody. Hope everybody's settled in. Nice cup of coffee or something like that. So today, what I'm going to be talking about is just firstly an overview of the prescribing situation for the Australian veterinary profession, including the current legislation and how high importance antimicrobials are used at the moment and in which species. I'll also provide some results of a survey we've done with Australian vets and international vets around the use of high importance antimicrobials and restrictions. And then finally, I'll discuss some research we're planning with human and animal health professionals to provide further guidance in this area, which is a Delphi consensus study. And I hope you'll enjoy it. I do go a little bit into kind of the historical background of some things, but I think it's important to know kind of how we got to where we are at the moment. So for those not overly familiar with the veterinary profession in Australia, on the clinical side of things, apart from university, charity and local government facilities, all veterinary practices are private businesses. So generally there are small to medium-sized businesses. There's a bit of increase in corporatisation at the moment, but practices can be quite small with just a sole practitioner or maybe one or two vets in the building, up to larger practices with 7 or 8, 9 vets. Specialty centres may have kind of 15, 20 vets at any one time. And there's also multi-site practices. Corporate practices will have additional layers of HR support, although this is usually, remotely, not actually in the building. All veterinary practices operate on a fee-for-service basis with very few exceptions. And specialist and emergency facilities are generally only located in major urban centres. So that does leave large geographical areas without access to a 24-hour advanced veterinary care service. In a lot of those regions of Australia, it'll just be a single vet who's on call, who might meet an owner at a practice or something like that. So prescribing legislation in Australia, it's the APVMA, the Australian Pesticides and Veterinary Medicines Authority, who has the legal power and responsibility for regulation of agricultural and veterinary chemicals in Australia. And that includes reconsidering approval or registration of a product if any issues become apparent due to research or issues in practice. And this can include public health impacts, among other areas. A more comprehensive summary of antibiotic use and the history of regulation can be found in the 2017 APVMA report called Antibiotic Resistance in Animals. And that highlights some of the key points of control for antibiotics in Australia. One of the things that sets Australia apart from some countries is that because we don't manufacture any antibiotics in Australia, all antibiotics must pass through customs. So we do have one way of kind of measuring the import of antibiotics that way. And veterinary medicine prescribing legislation can differ subtly in each state because there's different control of use legislation. And this is overseen by the State Department of Agriculture and their Chief Veterinary Officer. So there have been moves towards harmonising legislation at various times. There was meant to be kind of a report coming out this year about the progress in that manner, but it seems to just have stalled. So we've still got disparate legislation across the states. Since the 1970s, which is over 40 years ago now, the use of the vast majority of antibiotics in Australia has required a prescription from a veterinarian, and that vet must have knowledge of the animal and its medical condition, or the herd or flock and its medical condition. The exceptions to this are coccidiostats and ionophores. So these are medications that are used to treat protozoan parasites and also to prevent bloat in cattle, as well as other uses like growth promotants. And prior to 2014, the use of tylosin, which is a macrolide antibiotic, which was used to treat illness and also as a growth promotant, did not require prescription. However, this was changed from 2018. And along with other macrolides, it wasn't allowed to be used as a growth promotant. So this came about because of concerns about the potential to select for antibiotic resistance. And as a comparison, New Zealand had removed the label claims of macrolides such as tylosin for growth promotant purposes from 2001. So this is just for those unfamiliar with the antibiotics such as ionophores that are used or can be used as growth promotants in Australia. This table just shows the current APVMA registered antibiotics that have growth promotion listed as one of their uses. So for all of these, there hasn't been any cross-resistance with human medicines that's largely known to occur for any of these drugs. And also should be noted that 2 of the antibiotics registered for use in meat chickens are apparently no longer widely available despite being still registered for use. Fortunately in Australia, we were quite lucky that the use of fluoroquinolones have never been permitted in food producing animals. So this figure shows how in people our level of fluoroquinolone resistance is actually fairly low compared to a lot of other countries. Australia's right down bottom left-hand corner there. So that could be attributed to the regulation of fluoroquinolone use in Australia in animals, food-producing animals, and also in people. And gentamicin and colistin have also never been registered for use in food-producing animals in Australia. And also, if you're not familiar, food-producing, that refers to animals that are either producing food for human consumption, like milk or eggs, or they're actually used for meat. So it can refer to lots of different animals: cattle, non-ornamental fish, pigs, poultry, just as a few examples. It does cause some challenges for veterinarians who are treating animals, for example, like pet ducks or miniature goats that might just be pets, because it does limit the antibiotics and other medications that can be used to treat them, even if they're not going to enter the food chain because they're categorized as food-producing animals. But the use would be allowed in a dog or a cat, for example, because they're not considered food-producing species. So the 3rd generation cephalosporin, ceftiofur, is registered for use in individual food-producing animals, but it would not be allowed in a herd situation. And that's the only 3rd generation cephalosporin registered for use in food-producing animals. And another 3rd generation cephalosporin, cefovecin, is registered for use in dogs and cats in Australia. There's no 4th generation cephalosporins that can be used for animals in Australia, although there are in other countries. Also of note is that antibiotics registered for use in humans in Australia can be legally prescribed to animals, although this is more common in the non-food producing animals because the concern about residues entering the food chain or withholding periods doesn't apply. But this use must not be contrary to a specific label restraint, and other restrictions around the use in food-producing animals still apply. And similarly, off-label use is also permitted in veterinary practice, and this refers to a veterinary registered drug that is used for a different species or indication at a different dose rate or a different treatment interval compared to what's actually on the registered label. But if you're doing that, there must be a clear indication for the off-label use, such as a veterinary labeled product for that species not being appropriate or available. So in Australia, we generally have low use of antibiotics in animals and low levels of resistance in people and animals, particularly compared to obviously low and middle income countries, but also compared to European countries, depending on the classes of antibiotics that you're referring to. We also have a generally proactive approach, and we've got numerous restrictions compared to some other countries. For example, we've got the Antimicrobial Use and Resistance in Australia surveillance system, AURA. We've got a quite conservative approach to antibiotic registration. And we have the Australian Government National Antimicrobial Resistance Strategy, as well as the Australian Animal Sector National Antimicrobial Resistance Plan, which was last updated in 2018 though. So this figure is quite often referenced. It's from the UK Review into Antibiotic Resistance. It's showing milligrams purchased for every kilogram of livestock, milligrams of antibiotics. And it does not include ionophores or oligosaccharides. And what you can see here is that we have quite low use of antibiotics per kilogram of animal biomass, but it's important to note that the data used in this review for Australia is from 2004 to 2010, and this data was only published in 2014. Since then, we haven't had any published data like this for antibiotic use in animals. And the second figure is from 2017, and this is just to give an idea of the resistance of carbapenem-resistant gram-negative pathogens globally. And Australian data used for this was also from the AURA 2016 surveillance data. And just to kind of highlight that Australia, it is doing pretty well compared to lots of other nations, but I think there's always obviously room to improve, and we need to be proactive about this. A lot of the changes in relation to antibiotic use in animals in Australia can be traced back to the 1998 Joint Expert Technical Advisory Committee on Antibiotic Resistance, more commonly referred to as JETICA. And this was established by the Australian government. The role of the committee it was to investigate and recommend risk management strategies in relation to the threat of resistant bacteria spreading from food-producing animals to humans, with a particular focus on the use of antibiotics as growth promotants. So JETICA made 22 recommendations, and although they haven't all been implemented, in fact, I think there's more that haven't been implemented than have, they have provided the basis for some important actions, such as the removal of label claims for growth promotion on some antibiotics. And given that the recommendations were released over 20 years ago, I think it's heartening that now in the past couple of years, we're starting to see AMR being addressed with a greater sense of urgency. So in Australia, we still don't have a national system to measure antimicrobial use in animals, including livestock, other than sales data, which hasn't been available since that last lot of data was published or released in 2014. And the only other way to kind of establish antimicrobial use in animals has been through various studies using kind of sales data, pet insurance claims, active surveillance, just trying to get a rough estimate. And then also at NCAS, we've been doing some work with natural language processing of veterinary medical records as a way to look at antibiotic use. But obviously it would be much more convenient and proactive to develop a national surveillance system that could work in with something like AURA to show antimicrobial use and resistance in animals. What we do have though, which is actually pretty amazing given how long it's been going on, is that the use of antibiotics in Australia, like all other agricultural and veterinary chemicals, is I guess regulated in some sense because we have a really robust residue survey. So there's limits, maximum limits that can be, or sometimes it's zero on the residues that can be found in the food, the meat or milk from animals. And this requirement is monitored by the Australian government's National Residue Survey, and that was established in the early 1960s. So that's been going on for over 60 years. And I think that's something really positive about our food system and about monitoring antibiotic use in animals. So here, this diagram is also using the older data again. It's just showing the kind of volume of antibiotic use in animals compared to people, which is when measured by weight, 60% of our antibiotic use is in animals compared to 40% in people. Growth promotants comprise 4 to 7% of antibiotics sold for Australian food animals in the period of 2005 to 2010. So I think this is where kind of sometimes people talk about antibiotic use in animals being, so prevalent, and trying to say this is the problem in terms of resistance. But the other thing to consider too is that population-wise, animals are making up about 90% of the population receiving antibiotics compared to people, only around 10%. And another way to look at the situation too is comparing the annual exposure to antibiotics. So these infographics show how annual exposure to antibiotics is actually quite low amongst companion animals. So this annual exposure data for dogs and cats is taken from Hartefeld 2018 and was measured using pet insurance data. And so you can see that for people, this infographic is using the 2016 data from ORA, which showed that Australian population who had had at least one systemic antibiotic dispensed under the PBS was around 46%. In 2019, it's dropped down to 41.5%, which is promising, but you can still see that it seems to be kind of less than half of adults and over half of young children are being exposed in any given year to antibiotics, whereas with dogs and cats, it's kind of less than 1 in 5 dogs and around 1 in 10 cats. And I would suspect there is some data from the large animal industries reporting that the annual exposure is very, very low, particularly when you consider all our extensive operations in the north of Australia with cattle. They're not even going to be seeing a person, let alone an antibiotic, for the majority of the year. So back in 2005, the World Health Organization convened a drafting group on critically important antimicrobials for human health. And this group was convened in response to a series of workshops where it had been raised that we should have a list of critically important classes of antibiotics for people, because it would allow more targeted actions to prevent the development of resistance to these antimicrobials, and also allow more focused management strategies regarding their use in animals. So there were various criteria, which is what this diagram on the right shows, in how they developed the different priority categories. And the criteria used to group the antibiotics, taking into account their use in humans and animals, the seriousness of the diseases that were being treated, which diseases were being treated, and the ramifications if there was no other alternative therapy available, if that there was resistance developing to that particular drug or class of drugs. So this list was developed and termed the WHO list of critically important antimicrobials for human medicine. And this list is updated every 2 years. Now in Australia, we have the Australian Strategic and Technical Advisory Group on AMR, ASTAG, which is formed in 2014, but there have been similar advisory groups under different forms prior to that. So ASTAG is chaired by the Australian Government Chief Medical Officer and the Australian Government Chief Veterinary Officer. And there are over 20 organisations who are members of ASTAG, and it provides technical expert advice on AMR related issues. So ASTAG is responsible for publishing and maintaining the importance ratings and summary of antibacterial uses in human and animal health in Australia. So they've published this document, which is actually really useful, and it shows antibiotics registered in Australia as low, medium or high importance, depending on their use in human health. And similar to the WHO CIA list, it also takes into account other factors such as the possibility of cross-resistance developing and current levels of resistance. So as I said, it is based on the WHO list. However, the ASTAG ratings can vary a little bit depending on if our situation locally is different from a more global picture. And we may have antibiotics that, we have a lot of resistance to, whereas that may not be the case in other parts of the world. So that's generally why the ratings differ a little bit. So here is a table, and this is just comparing the rating systems to show that there's different countries and different organizations that can have their own rating systems. And even just working in a practice, you may have a practice-specific rating system as well. And you can see that, things that are rated penicillin G is low on ASTAG, but highly important and high for Canada. And it's also important to know that kind of if you're looking at the WHO system, it doesn't actually have the lowest that it can be on that system is important. So you do have to be aware of the actual categories of the rating system that you're looking at. And so as I mentioned previously, the only high importance rated antimicrobials registered for use in veterinary medicine are the third generation cephalosporins, fluoroquinolones and streptogramins, of which it's mainly virginiamycin. And it's interesting to note that in 1999, the JEDICAR committee actually recommended considering banning the use in animals of all antibiotics listed as critically important on the WHO CIA list. And if this were to happen, obviously it would dramatically change how vets practice and the options available to them when trying to maintain the health and welfare of animals. So I'll just pop that up there so you kind of see like that we would technically, if that had taken place, lose these antibiotics. But I think it's important to be aware of that and the privilege that we have in access to these medications at the moment and using them judiciously. So overseas, restrictions have resulted in lower levels of use of antibiotics that we would class as high importance according to our ASTAG system. And similar impacts are evident in relation to fluoroquinolones here and virginiamycin in pigs, and that if you're using them less, you're obviously less likely to get resistance developing. There haven't been that many large-scale studies to show this. A lot of it's kind of not been published. But globally, there was a 2017 systematic review and meta-analysis that found that interventions to reduce antibiotic use in food-producing animals did result in a reduction in the presence of antibiotic resistance bacteria in these animals. And there's also been evidence that withdrawing antimicrobials in food animals results in decreased antimicrobial resistance in humans. So in research carried out by NCAS that was using pet insurance data, in Australia, critically important or highly important antimicrobials accounted for 8% of all the antimicrobials prescribed over the 4-year study. This was largely in small animals, particularly for cats, the third generation cephalosporin cefovecin, and cats were actually 4.8 times more likely than dogs to be prescribed this third generation cephalosporin. In further research by NCAS Veterinary Group published in 2018, some of the enablers for implementing antimicrobial stewardship in veterinary practice were concern for the role of veterinary antimicrobial use in the development of AMI in humans, a sense of pride in the service provided, and preparedness to change prescribing practices. So there's definitely that feeling in the veterinary profession that they feel responsible for the use and they're open to changing prescribing practices and to learning. But it seems at the moment there's obviously room for improvement, particularly in relation to the third generation cephalosporin in cats. So some of the work that I've been doing is related to these surveys that were distributed to Australian vets and some vets internationally. In Australia, we had about 450 responses initially. After excluding duplicates and mostly incomplete responses, there was 322 complete responses. And this just shows the distribution across different types of veterinary workplaces, because the survey was open to all vets, like in university, academics, clinical practice, as well as vets in referral hospitals, emergency, industry and government. But you can see that the majority of vets, just over 200 vets, were in GP or first opinion veterinary practice, which I think is good because obviously it's giving you quite a a good indication of what people are thinking kind of on the ground at that first level of contact with owners. And also there was a really even distribution or proportional distribution across the states. The vet survey from overseas, there was 193 respondents from 22 countries. The vast majority of these respondents were from South Africa and the United States, and then some lower levels of numbers from other European countries. And the survey questions that we asked related to the use of high importance antimicrobials in veterinary practice in Australia or internationally, given whichever survey it was. And the questions related to whether or not respondents thought that there should be restrictions on these antibiotics or certain groups of antibiotics in the high importance category, as well as other, appropriateness of use of the high importance antimicrobials in a handful of case-based scenarios. And in the survey at the start, they were given an infographic and links to the ASTAG rating system if they're unfamiliar with this. So this is one of the questions that we asked the veterinarians. So this is the response from Australian vets. The question was, veterinarians should be able to prescribe antibiotics with high importance to human medicine without restrictions, and then looking for people's agreement or disagreement with that statement. So you can see that actually the majority of respondents disagreed that we should be completely free from restrictions. So I thought that was promising in that, you know, there's not just this widespread idea that we should just be able to prescribe whatever we like. And similarly, for the international vets, it wasn't quite so pronounced, but still just a small majority that also thought that there should be potentially, if you flip the questions, either some restrictions or just not a free-for-all in prescribing whatever antibiotics the vet wants to use. We then asked this question about if there were to be restrictions placed on veterinary prescribing of antimicrobials, which antimicrobials should it apply to? So this shows very strong agreement amongst more than 70% of respondents that all the high importance antimicrobials should be restricted. So this is over 70%. And also down here, it shows that the majority of veterinarians acknowledge that obviously we need antibiotics to treat animals and maintain their health and welfare, because there's only a very small proportion of hardcore people that think that all antibiotics should have restrictions. It's important to note that the type of restriction was not detailed in the survey. It was quite open. It wasn't talking about a ban or anything like that. It was just whether there should be some restriction placed on the use. The option to separate these categories, third generation cephalosporins and fluoroquinolones, or restricting high importance antibiotics but not fluoroquinolones, or restricting high importance antimicrobials but not third generation cephalosporins, that was provided because there are already veterinary registered products available in Australia for these classes of antibiotic, as opposed to high importance products, high importance antimicrobial products that are only registered for use in humans, like imipenem and amikacin. So for the same question to international vets, there was a subtly different order in the responses. So again, there was strong agreement amongst most respondents that the high importance antimicrobials should be restricted. However, it was the same proportion of vets that also thought that fluoroquinolones and third generation cephalosporins should be exempt from the restrictions. And this might reflect what vets are used to using in their countries where they're practicing, and particularly that they may be used to using these medications in a wider range of species. For example, like fluoroquinolones are permitted for use in pigs in South Africa. And I'm not sure exactly what their regulations are around third generation cephalosporins, but they don't seem to have the same need for the oversight of veterinarians and things like that in the availability of a lot of antibiotics. as well. So the jump from this current situation to having restrictions, it might be more in their minds. But once again, it also showed that the majority of veterinarians acknowledge that we need antibiotics to treat animals, as there's once again strong disagreement to restricting all antimicrobials. So in the survey, we also asked a number of case-based questions, which gave an idea of how vets may be using the high importance antibiotics. Obviously, what's indicated in the responses may not necessarily align with what is done in practice, because other research has detailed the numerous other factors that influence prescribing for veterinarians, such as the time constraints that they're under or perceived pressure from the client. But very similar proportions of agreement were obtained from international vets regarding these questions. So usually it's only a differ of a couple of percent either way. So in this scenario, the survey respondent was given the case of a cat presenting with a draining abscess on its face. And while the cat was febrile and inappetent, and you believe that antimicrobial therapy is indicated, you do not think that the infection is life-threatening. And so under which circumstances would it be reasonable in that scenario to treat this cat with cefovecin, the long-acting third-generation cephalosporin? So the majority of people, over 80%, thought that if the organism was resistant to low and medium rated antibiotics, then it would be okay to use cefovecin. I guess this is assuming that you've actually done a cold chain sensitivity, which in a lot of these situations would be very unlikely, because the rate of cold chain sensitivity in veterinary practice is really, really low, mainly due to cost, but that's also something else that our group is exploring. What's a little bit concerning and is an area for improvement is that so many vets, very slightly, just over half, about half, agreed that use was appropriate when the cat was difficult to medicate. And this has been a feature of the marketing of this particular antibiotic for cats, that, you know, it's so easy to give, it's a small volume, and it saves the owner of that having to deal with trying to medicate the animal. But I mean, realistically, the majority of cats are going to be fairly difficult to medicate, particularly if, you know, you're on your own or you haven't got someone to help hold the cat and things like that. You're not used to handling them. So I think just to put it into the category of, well, it's difficult to medicate, therefore we can use these high importance antimicrobials. It's just an area that we need to focus on a little bit more. And although another thing though was that there was still a fairly large proportion of people that thought that it was never okay in that situation to treat that cat with cefovecin. And I don't think that stems back to the fact that when you're treating cats with draining abscesses, because I'm in clinical practice as well, there are a lot of other options that you can use. It's just that there's issues around whether the clinic actually stocks them and other factors that are influencing why vets are choosing certain antibiotics, rather than that that's just all that they can use. So now kind of where do we go from here? So there seems to be general support or inclination towards some kind of restrictions from vets in Australia and overseas around the use of high importance antimicrobials, although obviously the surveys that I've done have involved smaller numbers. We don't have exact knowledge about what will happen with restrictions, whether they are required, what form they would take. There's some evidence that restrictions can be beneficial in reducing AMR in people and animals. And to develop the best future guidelines or policy, it would be beneficial to have consensus from experts regarding the use of high importance antimicrobials in veterinary medicine in Australia. So these could be supported by, you know, trials which are occurring currently regarding AMS interventions. But in terms of looking at the whole situation, I think that future studies really could benefit from having established consensus around the use of high importance antimicrobials. There obviously needs to be an awareness as well and consideration of the difficulties around implementing any kind of restrictions. The veterinary profession is operating in very different conditions to medical practitioners, although some challenges are similar. And because prescribing legislation also differs in each state, it's likely at the moment many veterinarians are not exactly sure of the finer points of the legislation they're practicing and prescribing under, despite their best intentions. So that is why I think that using some kind of consensus-based decision-making with experts would be the best way to move forward from where we are at the current point in time. So the Delphi method, this is a consensus-based method that originated in the 1950s. While there's some contention around its use in certain situations, consensus-based decision-making and Delphi studies have been used in many cases to establish the opinion of a group of experts, and that point is that they can develop a better outcome than an individual could because of numerous reasons. For example, having multiple points of view to draw on and the large breadth of experience amongst the group. So the Delphi method itself also has other benefits over a more informal meeting because it's anonymous, so you don't have the same influence of strong or dominant personalities kind of overly influencing the group dynamics. And also because it's anonymous, the input is provided through surveys with free text opportunities as well. So all participants should feel comfortable to provide their honest point of view. And usually 2 or 3 rounds of surveys are carried out to build consensus around the factors that have strong agreement amongst the group. And as I said, they can provide written feedback to accompany their responses. And then at the end of each round, the results of the group are provided back to them so they can see what the response has been and they can comment or adjust their responses in accordance with the feedback from the whole group. And generally consensus on any one point is taken to be about 80% or greater of the group supporting a given option or scenario. And group size can really vary from just over kind of 5 or 10 people, even up to 100 people. What really matters is that the group feedback is filtered back to the group in a usable fashion and a timely fashion, so that can all be taken into account and then used in the next iteration of the survey process. So the veterinary stream at NCAS are carrying out a study to develop expert consensus across veterinary and medical fields on the circumstances under which antimicrobials with high importance to human health can be used in animals. So there have been some guidelines developed around using the Delphi method for selecting healthcare quality indicators that have been published in a systematic review. And some of those points I've used as well in developing the process that we're going to be using, and it outlines how, for example, experts should be selected to clearly define the study objective and how the consensus criteria should be established. So as I said, our objective is to develop expert consensus across veterinary and medical fields on the circumstances under which high importance antimicrobials can be used in animals. And we'll be looking for participants across human and animal health who would be considered experts in their field in relation to antimicrobial stewardship, antibiotic resistance, or a related discipline. For example, infection prevention and control, microbiology, or public health. We would like to include prescribers and non-prescribers, including doctors, veterinarians, pharmacists, and other scientists or professionals. And participants from Australia and overseas are most welcome to take part, providing they have the relevant expertise. And participation will involve a series of short, probably less than 10-minute surveys using the Delphi method. And then subsequent surveys will present a summary of responses and ask participants to look at the responses in light of the feedback from the group, with the aim of building consensus over around kind of 3 rounds of surveys. So I'd like to finish by saying if anyone's interested in participating in our study, please express your interest. We can put a link possibly in the chat. I'm not sure if we can do that in this format, but there is also this QR code that you can scan, and that will just let you input your details so that we can follow up with you when we're ready to release the first round of the Delphi survey. And I'd also like to conclude by thanking my supervisors, Kirsten, Maura, and James, and my other NCAS colleagues. So thank you very much. And if anyone has questions, that's fine to go ahead. Thanks.
Anna, could I ask a question?
Mm-hmm.
That was a wonderful overview, and it's just great to see it all put together like that. And I hope all of our NCAS colleagues, wider colleagues, have an opportunity to look at the presentation. Can I ask, given that there seems to be, I guess, some consensus that restrictions would be appropriate in terms of, there's different ways of implementing them. Obviously, there are drivers from a government legislatory point of view, right down to the individual practice, and reflecting on your team's work, about how that restriction process might work at an individual veterinary clinic.
Sorry, I just missed a little bit of that because it just glitched out. You were just asking how the process might work at the level of an individual clinic.
How would a restriction process, how could that work at an individual veterinary clinic?
Yeah, I think that's where the Delphi will be useful, because some of the issues in individual clinics relate to like the legislation and the rules, and then there's other issues that relate to other areas that NCAS is working on, like education of vets and the availability of the drugs that they need and the practice culture. So I think like we have restrictions in place already on a lot of things, and like recording of our S8 drugs. So there is, I think it's feasible that there could be a system of restrictions that might include, you know, recording something, or, you know, clicking on a link or something on the internet and registering something. But from the surveys, when we had free text responses where people could write in, one of the things that's coming up all the time is that if it's going to be effective, it needs to be fast, because you need to be able to get approval as soon as you need it, basically. Or like if you're back on a property or something like that, you know, if you don't have reception, there needs to be some way to either, you know, use a drug and then record what you've done, or get approval shortly after or before, or something like that. Or it needs to be available 24 hours, because, you know, if you're just working by yourself at night, for example, that's may need to call up and get approval. So I think those are the things that would have to work through the process, but also once you get consensus, then it allows you to kind of better focus on how those restrictions could be implemented actually in practice. But I think it needs to work in with all those other factors that we're exploring too, not just restrictions, but around education and communication with vets and clients too.
Anna, there's a question from Stephen Page in the Q&A. You mentioned the widespread use of measuring quantity of antibiotic use in various animal species. What are your thoughts on the importance of assessing the quality of each use of an antibiotic?
Yeah, I think that's really important as well. And we obviously, I think in Australia, take for granted or just assume that the quality of our medicines is really good. And I think that that's something that should be definitely included in any kind of measuring process or regulation process around antibiotics, that we're maintaining a really high quality of supply as well.
I think Steve might also be referring to that there's an appropriate indication of use.
Oh, yeah, okay. Yeah, definitely. And I think that's helped a lot with the ABA prescribing guidelines too, that I think if vets are just in practice and just trying to do a good job, which I think most vets are, it does help them to have clear guidelines around what the indications are for when they should be using things, and that if somebody's not doing the correct thing or not following the guidelines, is a really clear way to say, hey, you shouldn't be doing that, you should be doing X, Y, Z instead. Yeah.
Anna, I have a question about the Delphi process, and just imagining you getting all the people from the medical sphere and the veterinary sphere together. How are you planning to, I guess, educate everyone in the room so that everyone's up to speed about the different challenges of different parts of veterinary medicine? For example, I would have no idea what the challenges are for feedlot cattle vets or for chicken vets. And I'm imagining that it would be even harder for people who come from the medical field to know what the challenges are. Is there a stage where you do a bit of, this is how it goes?
Well, we do provide summary responses. So if there's been a lot of free text responses highlighting some issue, for example, that will be fed back to that entire group so everybody's aware that something has been raised. And in the first round of the survey as well, we did have just a general overview of how veterinary practices operate in Australia. So people had that as just a little bit of background as well. But I think too, there will be probably a majority of veterinarians in the group, so that hopefully there won't be too much of them getting overpowered, I guess, by people who may not understand the situation on the ground. And then the other thing to consider too is, because it's going to be relating to high importance antimicrobials, there's not that many that are used in food producing animals at present that maybe need to be used. Right. So that's something else to consider, I guess. But I'm hoping that those kind of concerns would come out when people are able to explain why they've responded a certain way to a question.
Mm-hmm. Thanks.
It's helpful to reflect on the NAPS, which has been going since 2013, which has continued to grow over time across hospitals and aged care. And I think that our approach to reflect appropriateness of use is very palatable to prescribers, because it's a more nuanced approach than saying you're not guideline compliant. And in fact, it's reflected in appropriateness being 20 to 30% higher than guideline compliance actually, which again reflects the fact that we work in complex environments where patients may not necessarily be straightforward. And I'm sure there would be a similar situation in animal health where decisions have to be made, and they may not be optimal, but they may be adequate, and both of which are then classified as appropriate. So it would be interesting to hear your thoughts around that approach.
Yeah, I haven't looked at that a lot, so definitely it's something I'll have to compare when we're doing this Delphi process. Thanks, Cass.
I mean, one of the thoughts I've had for a while about restrictions is that for antibiotics where there should be a requirement for some susceptibility testing, the way to put that restriction in would be to require the approval of a veterinary microbiologist who's sitting in the lab. And given there'd be a commercial driver, then there'd be some pressure to maintain a service there. So the permission would be linked with the commercial drivers that apply in veterinary practice. How do you think that would work?
I think that would really help with the small animal practice issues where veterinarians are just using these antibiotics because they're convenient and they have them, and they don't feel that it's a big issue that they're using them. Where if they had to go through this extra step, I think they would just start with selecting something more appropriate initially. I think that it's obviously going to be always some pushback about people wanting to use whatever they want whenever they want. But I definitely think the use in cats, for example, some people say of the third generation cephalosporins is because there's not other options. But like I've said quite a few times, like how I would just use amoxicillin or something instead, and not even for an abscess, because what we know with abscesses usually flush them out. They don't even need antibiotics. But if you had, for example, associated cellulitis, so that's where I think that educating people that they could be doing something else, and then putting in those just little extra steps so that it's not so easy to use something that's high importance when you don't need to. And we'd also get better data then, I think, too, because as you know, there's not a lot of culture and sensitivity being done for the vast majority of conditions that are getting antibiotics.
Thanks, Anna. Stephen Page, I think you were going to put an editorial link in the chat, but you haven't put it in.
Yeah, I don't know if I can do it because I haven't got access to a chat on this.
Anna, Arjun has already put the link to your survey in the chat. I think
okay, good.
Glenn's referring to a message from Stephen Page about an editorial that's coming out and he was going to link to.
Oh, okay, cool. That's great.
Anna, it's James here.
Sorry, James.
Hi, James.
I was just thinking about Kaz's comments and thinking about your presentation. We talk about restricting access to certain antimicrobials. And actually, I'm going to let you off the hook and ask Kaz, in aged care or hospital settings, how would you put restrictions on prescribers for using particular antimicrobials, and would those restrictions then be applicable in a GP setting? Because that's the sort of the difference, I guess, in thinking about general veterinary practice. It's very applicable to GP practice. It's not like so Glenn's suggestion around a veterinary microbiologist in the lab is fine, but it doesn't address the setting where the vet's sitting out in the paddock somewhere and they're trying to, fish something out of the boot of their car to leave with the client.
Yeah. And I discussions with our practice colleagues, there are a lot of similarities. You're pretty much operating in an environment where you need to do something, you don't have microbiology available, the patients may not want microbiology, and you're working in an empiric space, and that happens in hospitals as well. So we have a traffic light approach where, of course, you could actually really restrict particular ones, and I in terms of the long-acting, one of the things that we do is we accept the fact that there needs to be empiric prescribing. So for common serious infections, you would never stop them starting the antibiotic, but there is that alert that it's a serious infection and should be reviewed, and that treatment is reviewed after a period of time. So it's more of a post-prescription process, which again, of course, doesn't generally happen in general practice because patients are often either given the course, a delayed prescription, and they in many cases will not return. What has happened and Arjun's been doing lots of interviews, and I sat in, I listened to one of the recordings a couple of weeks ago, is that with the new telehealth provisions, it has actually enabled GPs to be able to follow up microbiology results and call patients using the telephone approach, which is, of course, a rebatable item. And that's potentially has changed the landscape for GPs who can actually follow up. Now, of course, that's obviously different in veterinary practice. So the question is, accepting the fact that vets have to prescribe empirically, and there probably isn't commonly a post-prescription review process. I don't know. I think it would be for serious infections, but for the average cat and dog, it probably may not be. There needs to be a nuanced way how that might be, and that's where it comes down to that traffic light, where maybe we need to come down on particular drugs like the long-acting cephalosporins, which you really have no opportunity to shorten duration. That's it. And that particular one maybe should become a red antibiotic to allow the other. Because if there are alternative choices, then that is one approach. I mean, I guess that's sort of picking on one drug, isn't it? But that seems to be the problem child.
Thanks, Kath.
Is that a reasonable? Having listened to you talk having lots of chats with the other last few years, it's a bit of a wicked problem for the individual business owners and vets.
I was going to say, though, I think in general, veterinary practices are very good at following up individual patients. I don't know, potentially I think I would only be comparing my own experience of kind of human GPs, but because there is that business incentive to keep clients and keep clients happy, that some practices, like every animal that's sick would get a follow-up call a number of days later or have an appointment booked in for review. Obviously not all practices are operating like that, but there's certainly a lot of practices that do that. So if there was something to change with the antibiotic, or get them to stop or come back for another appointment to check how the progress is going, that process is already fairly well established in a lot of places. Obviously it's harder for large animals if you're needing to travel to the property, or they're having to bring like float a horse or something in. But the other thing to consider too is that something we've come across is just that in general, the history writing, the records, medical records are not up to standard. So that could be one way to improve things as well, and link it to using certain antibiotics.
Arjun, do you want to comment on, given all your recent work with the ARC?
Yeah, so I think GPs are really embracing telehealth from what they're saying in the interviews. And it's interesting, but it's also challenging. It's not something that is uncomplicated. There's a bit of equivocation about the efficacy of telehealth. But yeah, certainly that's something that's available through, it's a Medicare billable item now, and so it's certainly a different structure, but it's great to hear their perspectives on telehealth and the emergence of that through COVID-19. There was a comment there from Sally in the chat. Oh, I hear a lot of echo. Sally, if you'd like to comment.
I think you might have two microphones on, Sally.
Can you hear me?
Yeah, it's just a bit echoey.
I think you've got two microphones going, Sally. If you can mute one, you might be okay.
Was Sally's question in the chat as well?
Yeah, so it was about veterinarians who are working in agricultural practices, and so the implications of this research for them specifically, and yeah, generally, ensuring that those responsible for prescribing for very large animals, very large numbers of animals, example, pig, poultry vets, feedlot vets, are represented, I think.
Mm-hmm. Yeah, so I'm hoping that that will be covered in the experts that we include in the Delphi study, because planning to include a lot of people that have been involved in, hopefully, if they're happy to take part, like the guideline development for the AVA and things like that. And also just because of hopefully the numbers of vets that will include people from those diverse areas of practice. And I will be going through and making sure that we've kind of covered a lot of those fields when we're looking at the participants.
What's the timeline for the survey, Anna? How long are you going to run it for?
Well, looking at people that have done them before, usually if you have kind of a 2 or 3 week period for participants to respond to the survey, and then obviously we need a little bit of turnaround time to analyze the responses and get it back to them. It depends on, I guess, that time frame where we need to have the results with us. But hopefully it could all be kind of completed, I guess, depending on the rounds. If we do 3 rounds, maybe it could be done in kind of less than 6 months.
I think Stephen's left, Anna, but the editorial he put in there looks to me like it's arguing that studies involving the use of critically important antimicrobial agents in veterinary species should not be published. I guess the concern I have, going back to your talk, is the use of the WHO critically important agent list. Every time we've looked at this, we end up coming back to far preferring the ASTAG list, because there are some curious inclusions on the WHO list. Do you have a comment about which list you prefer to see restrictions imposed on the basis of?
I much prefer the ASTAG list too. I think it just makes a lot more sense, and it seems more, I guess I can understand the basis for the ratings a lot better. Whereas I guess if the WHO list has been created with trying to make something that's applicable for all countries across the world, can see why it would be quite variable. And I think it was macrolides too that they had rated a lot higher than Australia, and that was related to resistance levels in Australia compared to other countries. So I much prefer the ASTAG rating system, and that's what this Delphi study will be looking at: restriction of high importance antibiotics according to that ASTAG rating system. But I'll have to read the editorial. It sounds very interesting.
And Sally, did you want to have another go? Oh, the audio issue.